Okay, hello everyone. Extremely pleased to have Dr. Adam today with us.
So let's dive in. So I think it's helpful just to start with a brief overview of what transplant kidney pathology actually involves. Not everyone thinks about this every day like I do, so I think it's useful just to have a brief summary. Obviously, when a patient has end-stage kidney failure for whatever reason, often the only remaining treatment option beyond long-term dialysis is transplantation. The major problem with this treatment, however, is that the recipient's immune system recognizes the kidney transplant as a foreign invader and attempts to destroy it through a process called rejection. And as we currently understand it, this rejection process has two major subtypes. T-cell mediated rejection is represented by tubulointerstitial inflammation, as shown in this photomicrograph, and antibody-mediated rejection, as shown in this photomicrograph, as glomerular inflammation. Fortunately, however, we now have several immunosuppressive medications to at least partially prevent and treat transplant rejection. However, these obviously come with their own associated potential side effects, including increased risk of infection, such as this example of BK virus nephropathy. And transplant patients can obviously have many other reasons for poor transplant function, including ischemic insults, represented here as acute tubular injury. So yeah, the problem obviously that many of you encounter on a daily basis is that these issues often require different treatments but have overlapping clinical presentations. So our job as pathologists is to look at these biopsies and try to figure out exactly what's going on so that our clinical colleagues know what and how to treat. So as pathologists, arriving at the final diagnosis requires the integration of multiple sources of information, and we do have various tools available to us, including the standard pathology methods of light microscopy and immunohistochemistry. We also rely quite heavily on clinical history and other lab results, such as clinical chemistry parameters like creatinine and proteinuria, as well as obviously in transplantation, the presence or absence of anti-HLA donor-specific antibodies. And in kidney pathology in particular, we also routinely perform immunofluorescence and electron microscopy, and more recently, molecular diagnostics have become an important additional tool to the transplant pathologist toolbox. Okay, so what molecular methodologies are currently available to us in the field of transplantation? So with regards to intragraft or biopsy-based tools, the primary modalities include cDNA microarrays or gene chips, which I would consider to be the most firmly established in the field, nanostring, which will be the focus of most of my talk, and then other gene expression technologies like RT-PCR and RNA-seq. And it's also worth noting that there are obviously several established and up-and-coming blood and urine-based modalities that are also now available. So important to consider and be aware of those as well. But the focus of my talk today will be on biopsy-based gene expression tools. Okay, so just to provide a bit of clinically useful information to this relatively research-heavy talk, I just wanted to summarize what the current clinical indications are for gene expression testing in kidney transplant pathology. So this is a table from the BAMF 2017 meeting report, just summarizing the current scenarios in which intragraft gene expression testing is recommended. So just to break it down into three major groups. Essentially, the first is a number of scenarios where essentially the differential diagnosis is antibody-mediated rejection versus not antibody-mediated rejection. So an example of that would be when you have mild microvascular inflammation with positive DSA, but C4D is negative. So that's one situation where it doesn't meet the criteria, the official BAMF criteria for antibody-mediated rejection, but obviously it would still have some concern for the possibility of that. Yeah, obtaining as much information as you can from additional ancillary testing would be useful. The second scenario is essentially when you have a borderline infiltrate and you're concerned about T-cell mediated rejection, but you're not clinically confident enough to initiate treatment. So that's another situation where ancillary gene expression testing may be helpful. And then the third situation is this specific scenario where you have C4d negative isolated